We have all our speakers in.
I'm moving a few folks over still. There we go. One more, Lori. Just about. Okay.
Okay, are we ready to go?
Okay.
Okay. Hello, everyone. I'm Laurie Soman. I'm Senior Policy Analyst with Lucille Packard Children's Hospital, Stanford, and I direct the Children's Regional Integrated Service System, CRIS. I'll say a little bit more about that in a minute, but first let me introduce our interpreter, Maria Martin. Maria.
Thank you. Hello, everyone. My name is Maria Martin, and I will be your Spanish interpreter today. We will have a couple of other interpreters in the different breakout groups that will interpret for each particular group. Everything said in this meeting will be confidential, and be aware that I might interpret everything you say, okay? And please speak directly to the camera in this case. And please make frequent pauses for me and for the other interpreters to interpret in the best way possible and the best accuracy possible. If I need a pause or for you to stop for whatever reason, I may interrupt by raising my hand. Buenas tardes, mi nombre es María Martín, perdón, y yo voy a ser su intérprete de español en esta reunión. Va a haber otras 3 intérpretes que estarán interpretando en los diferentes grupos de discusión. Todo lo que se hable en estas reuniones será confidencial. Por favor, sepa que debemos interpretar todo tal como se dice. Por favor, hablen en frases cortas para que así podamos interpretar de la mejor manera posible y con la mayor exactitud. También, si tenemos cualquiera de las intérpretes la necesidad de una pausa, lo haremos levantando nuestra mano. Muchas gracias. Thank you very much.
Thank you, Maria. Back to Laurie here. So I said I'd say a little something about CRIS, Children's Regional Integrated Service System, that I direct. It is a 32-county collaborative of county CCS programs, children's hospitals and pediatric organizations, and family support organizations, including Family Voices. And our goal is to promote a more effective and family-centered CCS program. So I'm really pleased to welcome you to our breakout, partnering to make the whole child model work for CCS children and families. We have a wonderful group of panelists, and I will introduce them to you in just a minute, but first, just a little bit of housekeeping. So you will see a poll on your screen, and I see you're already completing it, just to give us an idea of who's attending today. We will hold questions till the end of the presentations, but please put your questions for the speakers in the Q&A section, not the chat, the Q&A. Feel free to use the chat to introduce yourselves, to share information or resources or your thoughts about what's being said. And then, of course, you already have heard from Maria about the interpretation. Before we start, I want to thank Allison Gray of the Lucille Packard Foundation for Children's Health, my co-planner for this breakout, because truly this could not have happened without her. So thank you so much, Allison. Okay, so this breakout builds on the information you heard this morning in the CCS plenary session about the expansion of the whole child model. This year, as you heard, Kaiser implemented whole child model in 8 counties that were already whole child model counties, but now Kaiser is a player in that particular arena. And then in January 2025, 12 new counties will be converting from classic status to whole child model. So our goal here is to consider how we, all of us, families, providers, advocates, counties, plans, can partner to improve how Whole Child Model operates for CCS kids and their families. So let's introduce our speakers. From the county perspective, we have three folks. Lael Lambert, who most of you, if you were in this morning, you would have heard Lael speak, the Nursing Services Manager for Family Health Programs with Marin County. She oversees the county CCS program. Meredith Wolf is the CCS Administrator for Humboldt County and a parent of a child with hemophilia. Francesca Peterson is the Director of Children's Medical Services for San Luis Obispo County, and she oversees that county's CCS program. Our county reps will explain how Whole Child Model differs from the Classic CCS model. Next up, we've got Mira Morton with the Advocate perspective. Mira is Vice President of Government Affairs with the California Children's Hospital Association. Mira will review the lessons we learned from the recent evaluation of the CCS Whole Child Model and the additional requirements for the State Department of Healthcare Services and Whole Child Model plans as a result of that evaluation. Next up, we have two parents speaking from their perspective. Emily Watson is a parent of two children in Santa Barbara County. Her older child was diagnosed with brain cancer. Laurie Sato is a parent of two children in Orange County. She is the caregiver for her 8-year-old child with medical fragility and multiple disabilities. And she also has a 14-month-old son. So Emily and Laurie will talk about their experiences with CCS Whole Child Model, what has worked well, where there may have been challenges, and any kind of changes they'd like to see to improve how Whole Child Model works. And then we have our plan representatives. We have Nicole Hartigan, who is the Associate Director of Care Coordination with Partnership Health Plan of California. And two folks from Kaiser. We have Dr. Jerry Cheng and Gina Annixter. Dr. Cheng is the Regional Lead for Pediatric Specialty Services with the Southern California Kaiser Permanente Medical Group. And Jerry, I believe you're a pediatric hematologist by training. So you bring that expertise, is that right?
Correct, and transplant, thanks.
And transplant, thank you so much. And Gina Annixter is the Director of Medicaid Care Coordination for CCS and Complex Youth with Kaiser. So our plan representatives will explain how they are implementing these changes that are required in Whole Child Model to address the new requirements and to talk about their plans for expansion into new counties. So with that, I will hand it over to Lael and kick us off with the county perspective.
Good afternoon. You've heard from me already this morning, and you've heard a lot of what are some of the things that we've done in order to set up Whole Child Model and make it successful in our counties. And what this presentation, as Laurie's already said, is talking about the differences between Whole Child Model and Classic models. So I'm going to introduce the first slide, and then my illustrious colleagues will be able to take it from there. So the basic difference of CCS Classic counties is Classic counties determine eligibility, case manage, authorize services, and pay the claims with collaboration from the county. The Whole Child Model counties, what we do is determine medical eligibility. The managed care plans are responsible for providing case management, medical case management, authorizing services, and paying claims. There's a lot of differences or, as I said this morning, concerns about how things are termed, and both Meredith and Francesca will do a lot more of that discussion. So I'll send it over to Meredith.
Thank you, Lael. So next slide, please. The one area in which there are differences due to the two different systems is with the approach to case management. One reason case management is different is because of the two very different systems delivering CCS services. So the county CCS program, usually in the public health department for Classic, or the managed care plan for a Whole Child Model. CCS in a Classic County is customized for children with complex healthcare needs. So in a Classic County, the population that the county is responsible for is children and youth 0 to 21 with CCS eligible conditions, and that's it. This means that a Classic County can create policies and procedures that take into account the complex needs of just this population. In a whole child model, the managed care plan is responsible for the entire Medi-Cal population residing in their service area of multiple counties. Because of the large scale that they serve, processes are more standardized to serve the entire Medi-Cal population of both children and adults. What this looks like in CCS in a Classic County, a child will have an assigned public health nurse case manager who provides proactive medical case management for the child. The county nurse case manager works in the same county that the family resides in and is familiar with local providers, vendors, local resources, and the child's medical therapy services if they're getting medical therapy. The public health nurse case manager becomes familiar with each child's history and care plan. In Whole Child Model, currently CCS families access the managed care plan by calling a call center or a member services line, but new rules will require the managed care plans to provide a primary point of contact to parents of children in CCS in a Whole Child Model. So we hope that this will make it easier for families to get help navigating the system, and that help would come from a nurse who has experience with CCS conditions and providers. Next slide. So another difference between Classic CCS and CCS in Whole Child Model is related to the way providers are authorized. In a Classic County, the county authorizes a CCS paneled provider. Any CCS paneled Medi-Cal provider can be authorized regardless of where a family lives. This opens up access to the most appropriate provider for a child's condition, even if the best provider for a rare condition is across the state or beyond. In CCS in a Whole Child Model County, managed care plans authorize providers who are in network with their health plan. In a Whole Child Model County, children are still supposed to be followed by a CCS panel provider, but the provider does need to be in the managed care plan's network or has to agree to sign a letter of agreement with the plan. So again, since managed care plan processes are designed for the entire population of Medi-Cal recipients, there is no mechanism yet to ensure that a CCS panel provider is authorized for the CCS population. Next slide, and I'll pass it over to Francesca now.
Hi, good afternoon, everybody. Thank you. So another key aspect of CCS is case finding, where anyone can refer a child. And that's very key, because one of the reasons CCS exists is to ensure that children who need specialized care are found and enter this system of care that will ensure they are going to the right provider for their unique need. So although the primary care provider is a common and often the most likely source of a referral, if a child is not getting primary care due to perhaps a geographic barrier or a social barrier, CCS encourages referrals from anyone so that children are found as upstream as possible to have the best possible outcome for their condition. Notably, CCS is a public health model. And in contrast, Whole Child Model is a managed care health plan model. Next slide, please. So further to case finding, in CCS Classic counties, counties have in place procedures to identify and find failed metabolic and hearing screenings, and that those kiddos and those children receive intervention as quickly as possible. And this includes newborns without Medi-Cal. What we do see, though, and it's notable, is that there are delays in care for children who have metabolic or hearing screening disorders, and that can result in greater cost to society over time, of course. Early care by the right specialist can make a really big difference. And a family without Medi-Cal needs help navigating the healthcare system quickly for a newborn as much as anyone else, which is one reason why CCS includes diagnostic services regardless of income. Next slide, please. Another area that has been a struggle, frankly, for the counties in Whole Child Model is the annual medical review process. And this really correlates a lot with the case management model as well. Currently, and fortunately, now managed care plans, this is a recent change, are now responsible for requesting records from providers and sending them to the county CCS for the AMR. And AMR's annual medical review, the AMRs, this is the annual medical eligibility renewal. They have been problematic and a challenge since the transition to Whole Child Model in 2018 and 2019. Counties are responsible for determining ongoing medical eligibility based upon a review of current medical reports from CCS panel providers, physicians, and special care centers. What we have found is managed care plans do not gather and retain medical reports to ensure that the client is receiving the necessary care and going to their appointments. And they don't conduct medical case management the same as the counties. Managed care plans are now responsible for providing counties, as I said, with medical reports for each diagnosis per the most recent APL. And in concept, these reports should be readily available to the managed care plans through the medical case management that they are responsible for providing to clients. But what we do see is that the result is that the counties are still not receiving the necessary medical reports for all the diagnoses that we need to determine ongoing medical eligibility. And so what happens is instead counties note in the state database that no records were received from the care plan, managed care plan, and eligibility is extended based on ongoing chronic medical condition or some other notation, or perhaps closed to CCS for no services. An example of how this impacts the families is that when counties conduct the annual medical review, one of the things that we're finding is that when we review what reports we do have available, we're finding that children may perhaps have not attended the needed medical appointments, or are not seeing CCS paneled providers, and so are not receiving the medical care that they are needing and entitled to. Important appointments are delayed, and the health of the children can be detrimentally affected. And a couple of examples of this, kind of demonstrating the difference in the medical case management model is, for example, a child was identified with congenital displaced lens, for example, and we're supposed to be seeing an ophthalmology annually for ongoing care. And at the time that a annual medical review was done by the county, it had been 16 months since that child had been seen. And when that county reached out to the managed care plan to see if a case manager, a nurse case manager could reach out to the parent, the plan responded that the patient does not meet the complex case management criteria and therefore is not assigned a case manager. Now, I will say that a lot of this is in process and working with the plans, and the state and the counties are working with the plans to help improve this situation. But these are some of the things that we've seen. Another example is a child who was opened for hearing loss. And at the annual medical review in year one, it was noted that the child still did not have their hearing aids. Another year later, at the annual medical review, reviewing reports, the county noted the child still did not have a hearing aid. And it took, in fact, 3 years for this young child to actually get their hearing aid, which to a young child, 3 years with hearing loss is extremely significant. So the point of this is to exemplify the importance of the annual medical review and the importance of the medical case management, which is a key function of CCS in ensuring that these children do get the right care from the right provider at the right time. Thank you. Turn it back over to the panel here.
Thank you, Francesca, and thank you, county representatives, for a good overview of the differences between these two still very different models. Now let's turn it over to Mira Morton of CCHA to tell us what we learned from the whole child model evaluation and what steps are being taken as a result.
Thank you, Laurie. Next slide. There we go. So hello, everyone. I am here to kind of talk about the advocacy journey that we've been on, and particularly if you are a family member or you work directly with family members. I think what I'm really hoping you get out of today is a sense of what the law, what safeguards exist in the law, both as a result of SB 586, which is the law that established the whole child model, and subsequently in AB 118, where we add additional protections, because family members are always the most powerful, effective advocates for children, especially in CCS. But it's very difficult to advocate for things if you don't know what you're entitled to. And also, I'm going to kind of build on what you just heard about, which is where do we think the gaps kind of exist, and policies and procedures are going to need to be built up in whole child model plans to make sure that children are getting the same care regardless of what county they are in as part of CCS. Next slide. So the goal as we worked on SB 586, this was back in 2016, to establish the whole child model for advocates, was to preserve as many of the strengths and protections in the CCS program as possible for children who were moving into the whole child model county. And this involved trying to ensure that the relationships that they had with their existing CCS providers, their nurse case managers at counties, if possible, that those relationships were maintained, because for families, those are the people that knew them, those are the people that knew what they needed, and we wanted to make sure that they continued to get kind of seamless care. So for example, SB 586 included 12 months of continuity of care requirement. I think many families still don't know about, and also asked counties whenever possible to hire nurse case managers to help do the case management at the county level. We also required adherence to the CCS standards and referrals to CCS special care centers and CCS panel providers, requiring, and I already said, case management by individuals with experience. So what we ended up seeing was that in general, plans were not able to or did not hire nurse case managers to do their case management. So the law does require them to use individuals with experience working with this complex population. And then SB 586 also contained this important requirement of an evaluation once we had 3 full years of implementation data in all whole child model counties, and to compare what was happening in whole child model counties to classic counties to see if, as the state's goal, that kids within classic and CCS were receiving the same or better care once they moved to whole child model. My computer is doing weird things. It's just me. We also extended the carve out of CCS from managed care in all the other counties until that evaluation could be completed, because we didn't want to have new children moving into the whole child model until we knew it was working and we knew that managed care plans had the support they needed to make it work. And also ensuring that children were identified and referred to CCS was a requirement in that law. Next slide. All right, so early last year, we saw the evaluation that was completed by researchers at UCSF. And again, the goal of that evaluation was for the state was to identify whether children in whole child model were doing as well or better than children in classic. And for advocates, once we kind of realized that in fact that didn't happen everywhere, our goal was to figure out where and for whom the whole child model did not meet or exceed performance of Classic CCS. Now, because that was our goal in reviewing the evaluation, what I'm going to kind of walk you through is the negative findings. I want to be very clear that there were positive findings in the evaluation. The whole reason that the whole child model exists is because there's always been a little bit of fragmented and disconnected care when you have Medi-Cal managing your Medi-Cal managed care plan managing your primary care and your non-CCS care, and then you have a county managing your CCS care, you can end up with disconnections. And so there were examples of places where the whole child model actually did help families and did improve some outcomes, or at least did do as well as their whole child model. But I'm going to highlight some of the big areas where we were very troubled by what we saw in the evaluation, and we're going to be working to see if we can support whole county organized health systems as they implement. The first is drop in CCS enrollment. So we saw an average 10% decline in enrollment in CCS. These are kids that had already been in the CCS program. And then across all three phases of the whole child model, we saw new enrollment drop, potentially because of things you heard in the last presentation about there's not maybe as robust a case finding mechanism within NICUs. But we also may have kids moving out as part of that the annual medical review, and then they don't get brought back in. So we're still trying to identify reasons why that's happening so we can help improve that. But that was a big concern that we had going in and a finding that we found from the evaluation. Other findings that were inconsistent across the plans, but definitely we saw them in certain whole child model counties. In general, fewer primary care visits and well child visits, fewer specialists and CCS provider visits in particular. So even if they were getting to specialists, they may not have been CCS panel providers, fewer annual special care center visits than in Classic CCS. Again, not uniform, but the fact that we saw that it all was a concern, and those are areas where we want the department to be working with plans to make sure that those results do not stay that way over time. In general, CCS whole child model was less likely to ensure specialty visits were with CCS panel providers, as I've mentioned. Partnership health plan was not able to provide referral data, so we don't have a clear picture. And I think data in some places just was an issue. So we are working with the state to try to improve the sources of ongoing data to make sure that we can track how these markers are changing over time. Families and key informants, which includes county CCS workers and providers, were also interviewed. Many families indicated they did not know that they could ask for continuity of care. As I mentioned, that is something that you are entitled to under the whole child model for at least 12 months. Although at least 90%, it looks like from the surveys, were able to stay with their providers. So that's a good sign. But we want to make sure people know about that requirement. Next slide. A really, really big difference, which we always knew would be the case from CCS Classic to whole child model, is that case management shifted a lot. I think we included as many safeguards in 586 as we could to try to prevent this or minimize this difference. But families pretty broadly reported that case management was not centralized or coordinated by one person within the plans. Instead, they would have to call a central number, and then they would get transferred around to different departments within the plan based on the particular need they had. Whereas in Classic CCS, you're able to call your nurse case manager, tell them here's the 5 things you need help with, and they get it all taken care of. The other thing that families reported and key informants reported was that case managers were often not familiar with CCS medical conditions. Again, something we had foreseen, an area where we definitely want to see improvement over the next few years. So if you hear about this, let us know. There was not a lot of information, and the evaluation noted this, that this was not an evaluation that was designed to look at subpopulations within the CCS population as a whole. So we don't have much information about were there particular groups of kids that didn't do as well in whole child model as others, but we do have kind of anecdotal information from families who those who describe their children's health as poor were much more likely to say that care was worse in whole child model. And so we think the more complex the care is, the less likely it was to go smoothly in the whole child model, probably because case management is different, it's more fragmented, and because of all the things that we've already been talking about. Next slide. So coming out of the evaluation, the department was interested in adding more counties to the whole child model. This is partly because a bunch of new counties were going to be becoming part of the county organized health systems that were already participating in the whole child model. And then also there were 3 counties that are proposing to move, are going to be moving from multiple plan counties to single plan counties. That was Alameda, Contra Costa, and San Bernardino. And so the state proposed moving all of them into the whole child model. Having seen the evaluation, we were obviously very concerned about immediately rushing to add more kids to a system that already has lots of kinks to work out, especially those enrollment numbers. But after talking with them, I think we felt that it was fair and probably just as problematic to not move all of the COs, the new COs counties into whole child model, since then you'd have a county organized health system with kids in different systems. It's probably not going to work well for families or for the plan. But we did push back on the single plan counties who were going to be new health plans, that they should not immediately be serving this most complex of populations. So AB 118 limits the expansion to the new counties joining county organized health systems. It extends the CCS advisory group, whole child model advisory group, through the end of 2026 to make sure that there's lots of time for stakeholders to continue working with the department and with our plan partners to kind of troubleshoot things that showed up in the evaluation. It required DHCS to create more CCS specific utilization and quality metrics so that we can, and watching enrollment trends so that we can start to track whether those improve as plans get more experience and implement corrections based on the results of the evaluation. And then finally, for families specifically, we directed plans to require have a single point of contact at every plan to coordinate care for families so that they don't have to talk to 5 people to solve 5 problems. They don't have to go through phone trees. So to the extent that you are finding out that this is not happening, plans are doing their best to get everything implemented, but it's a lot, that we knew this population was going to be tough. And so we want to make sure that we find out and they find out when things like this are not happening. So just want to make sure you're aware of the new requirements. Next slide. So we are in implementation. AB 118 passed last summer, and now we have a new all plan letter that went out to whole child model plans at the end of the year last year. It specifically references the primary point of contact for CCS families, and it also directs plans to make sure that they're making referrals to CCS, which we saw a big loss of in the whole child model. Oops. The CCS Performance Measures Quality Subcommittee is in the process of finalizing CCS specific utilization and quality metrics that will go on the state's whole child model dashboards. We'll be able to track more specifically how specialty care is going in Classic CCS versus whole child model. And then advocates, plans, the department, families, everybody, we're all monitoring those trends and are going to make sure that plans are improving and working towards that goal that the department ultimately had, was that whether you're in the CCS Whole Child Model or Classic, you're receiving the same level of care. And so you can certainly have a role in that, particularly during this time when there was continuous enrollment required during the pandemic. That has ended. And so what we're seeing is a lot of people, through sort of just process reasons, lost access to their medical. Some of them lost access to CCS, or because your annual medical reviews are causing people to be lost to CCS. We want to make sure that they get brought back in. And that can be a little more challenging for health plans who are not allowed to market. They're not allowed to go get you. So as much as the rest of us can be helpful in trying to direct people back to their whole child model plan, that will be helpful to help bring those enrollment numbers back up and make sure that people have access to all of the protections and all of the services that are available in CCS. All right, that's it for me.
Thank you, Mira. And let's switch over now to our 2 family members talking about their family perspective and hopefully some good suggestions for how we can make the whole child model work better as it expands in 2025. So Emily Watson and Laurie Sato. Emily, you want to start off?
Hello, my name's Emily Watson. I'm here because I'm my daughter has been a recipient of the Whole Child Model and CCS for about 5 years now. And I will get to share some of my experience with using the system. She was diagnosed with medulloblastoma, which is a brain cancer. She had a tumor that was 3.5 millimeters in the base of her skull, covering her cerebellum, which cerebellum is the motion sensor for the brain. It tells the body how to move, and so she's had a lot of physical disabilities because of that tumor. She was diagnosed on St. Patrick's Day 2018, and 2018 is the same time that Santa Barbara County moved to the Whole Child Model. So I was just doctored right into the Whole Child Model. I remember the process of that just being kind of seamless, which says a lot for the program. I remember just being told by a social worker that because I was already on Medi-Cal, that we would be directly put through CCS, and that we would never see a hospital bill, which has been true for the most part. The only bill that I did see was my daughter was transported just when she was diagnosed from Santa Barbara to UCLA by helicopter, and I did see the helicopter bill. But other than that, I have never seen another bill the entire time. So that has been a relief to be able to not have to worry about the financial part of the insurance. So I have a 3-year-old here with me. Okay, you can do that. Here, pick a different game. We can do my cat in a minute. It's okay. It's fine. Please. We will do it in a little bit. There you go. She is now been cancer free for 5 years. She's 12 years old now, and she's doing pretty well other than side effects. She loses her balance, has struggles with handwriting and speech therapy. Lucy, it's okay, honey. It's okay. Here you go. And let's see, as far as like experience using the Whole Child Model, we've had, we use the MTU, which is the medical therapy unit. She's been seeing physical therapy and occupational therapy there. And one thing that we would like to see within the therapy unit is to really feel the whole child model. I mean, it's a whole child, but through MTU, they often will only work with these kids for like the very necessary things for living. Like my daughter has problems with handwriting, and they won't help her with handwriting because it's not a really big life skill. They figure that the school can do that, but the school isn't getting her up to grade level. She's 6th grade now, and she probably writes like a 2nd grader or a 3rd grader, and it would be really sweet to be able to see that. Also, it was a long process to get her a wheelchair, so that process to get that chair could definitely be shorted. We also had a problem with calling to get a provider that we were happy with. So that process was just really difficult for us. And also getting specialty medicines has been an issue too. That's taken like 8 months of trying to get things like growth hormones. Just the insurance process just took forever. But for all, we have enjoyed the CCS model, and it's been working for us. There's just like a few things that could like improve in helping my child get everything she needs, but we're grateful for the program and grateful that it exists. Thank you.
Thanks, Emily. Laurie.
Hello, everyone. My name is Lori Sato. I'm the parent of an 8-year-old child with multiple disabilities and global delay caused by a genetic condition. So my daughter was diagnosed in utero with a condition called hydrocephalus, which is swelling in the brain. And because she was so young and there was not a lot that they could tell us about what that would look in terms of impact on her life as she grew older, it was very challenging. And as she grew older, we were able to find the exact cause of that hydrocephalus, which was a rare condition called Fukuyama congenital muscular dystrophy. It's very uncommon to find here in the States, but she is affected in all areas. She is a full support kiddo. So part of the successes that I've found through some of these programs were the early identification of the vision loss, early identification of the hearing loss. She had a feeding tube placed very early, which helped her gain weight, and was identified very early for her orthopedic impairments as well. So CCS has been crucial for us to obtain some of the specialty equipment, a standing frame to help her stand. She cannot stand or walk independently, wheelchair as well. And also has been able to help her as we might have experienced some challenges with lapses in her PT and OT therapy services for various reasons. So part of the reason that I am really glad to speak about the successes of the program here today is that before Whole Child Model, we were having a lot of difficulty with our case management until we got referred to a complex case manager. And I hear that through other families that I'm speaking with, a lot of the ones that have a complex case manager that are familiar with these CCS kiddos has been really crucial for them to understand kind of all the different agencies that are working with our kiddos and understand all the different kind of areas that we might need assistance with. So I think that has been a really big factor for my child. And so I hope that the plans as they move forward with Whole Child Model can really learn from that experienced person working with these kiddos, it makes such a huge difference. You have somebody who would really understand kind of the challenges that the families have in terms of, just trying to do the day-to-day care for some of these kids. And you would also have someone who understands kind of the hiccups that might arise and also has the ability to sort that out. We have so many different agencies here in Orange County that are a part of my daughter's care. We have our home health nursing that is an element, and we have the agencies waiver agencies that are an element, and we have the regular doctors and the specialists, and the school is a whole nother thing where we have her educational access as well. So I think that was a really key thing that helped us, is having a complex case manager that understood needs like my daughter was to have. Another thing that was very interesting as I was listening to some of the presenters was I felt like my daughter having her vision needs and hearing needs identified early was such a crucial factor for her development. And I hope that as the plans go forward, they really look to CCS and what they have done to implement these things. My daughter has a minus 2250 vision, so extremely high myopia, and she has severe hearing loss bilaterally. So if you don't get the proper interventions early, it severely limits these children's abilities to communicate. And we were lucky enough to be referred early to Blind Children's Learning Center and to other areas that have a total communication system so that we could start that immediately. And we learned a lot about those systems to help her communicate as she got older, so that now she's working with the eye gaze and she's doing a great job with it. So I think that keeping that communication access available to these kids, and also kind of setting up the parents early so that they can help their children as they age, is also a major portion of the whole child model. And lastly, I feel like as we've kind of gotten older with the program, that some of the other challenges that we have is that we're finding when we go to our MTU for visits, that because of the changes, they're not too sure what is expected of them in terms of equipment, or what might be approved on somebody's MOU and maybe not on another's. And so they're a little hesitant to recommend certain pieces of equipment because they don't know what's covered and what's not. And so I think that the other challenge that we're finding is just making sure that people who are working with these children on a day-to-day kind of basis have access to the information that they need to be able to do their recommendations appropriately. But we are very grateful that this is a program that is part of our care, and we are looking forward to seeing what the changes will mean. Hopefully it will be more integrated, and we will see kind of a improvement in some of the service timings. But I'm very grateful to be a part of this, and thankful to be here today speaking with you. Thank you very much. I'll also put my information in the chat. If there are any parents that have questions about our personal experience, feel free to email me or any of the other providers. Thank you so much for your time, everyone.
Thank you, Laurie, and thanks, Emily. Let's turn it over now to our plan partners, talking about how they are implementing the changes that were detailed by Mira earlier and preparing for expansion. And I'm hoping that perhaps the plan folks can also pick up on some of the points that the family reps raised: better coordination, early intervention, the need for, I mean, I would say every CCS child should be part of a complex care management program because of the nature of them being eligible for CCS. But talk a little bit, maybe you can address how you identify and assure that kids are getting the right level of care management. On the other issues, like DME, that's everybody's nightmare, right? So, and I know we gave the plan folks some very specific questions to address. So see if you can work any of this other stuff in, and if not, we'll pick it up in the Q&A. So let's start with Nicole Hardigan with partnership.
Thank you, Lori. Well, good afternoon, everyone. And absolutely, Lori, I was taking some notes and some information down as everyone was speaking to be able to kind of follow up on some of the things that have already been addressed. So just to reintroduce myself, I'm Nicole Hardigan, and I'm with the Care Coordination Department here at Partnership Health Plan. This is my very first Family Voices Summit. I am actually really happy and honored to be a part of this conversation and this collaborative effort to just highlight and improve services for our patients and our families and our members. So thank you all for having me. Go ahead and go to the next slide, please. So as you are aware, and as you can see here, the partnership footprint is quite large. We did expand into 10 new counties this year, which are the counties that are Tehama and Plumas, Glen, Colusa, and to the eastern region border of Nevada. And in those 10 counties, that does include a pretty high volume of CCS children. It's around 4,400 CCS children that we welcomed into our health plan this year. And that's on top of the ones that we have already been serving, which are somewhere around 9,000. Just to give a little bit of background about our care coordination team, we have offices in all areas of our footprint. So we have 6 offices now, and we have care coordination representatives in all of them. So our mission and our drive is to definitely have not necessarily nurse case managers in every single county, but at least local representatives who know the resources and the community challenges and barriers very well. And we continue to welcome that conversation and learn more about our counties. Next slide, please. So partnership has been implementing the whole child model for the last 5 years in our current 14 counties. We have a lot of services and strategies that have worked over the years to meet the needs of our members, and obviously room to grow, but a lot of our strategies we're going to implement into the 2025 whole child model expansion. And absolutely our goal is to ease the transitions, continue to build relationships, and facilitate access to care, and also meet the new guidelines of the Assembly Bill 118. Next slide, please. So I think that some of the county partners had already touched on this, but one of the ways that we address the primary point of contact for all of our children, and there's going to be some sort of blend of this moving forward in the future. Our care coordination department has a team approach, providing case management to all of our members. And primarily our CCS children are assigned to nurse case managers because they are our clinical experts. There's a kind of a process that it works between the social workers and the healthcare guide, depending on the need. But we do have a team approach. They are very patient-centered and they provide services for all conditions. We not only focus on the CCS diagnosis condition, we also provide case management for all needs. So there's no reason for there to be multiple conversations. It's one case manager for all the needs, whether or not it fits into the CCS condition. And then this is also an opportunity where we really lean into the annual medical review process, not only to meet the requirements of the yearly eligibility, but also we see this as an opportunity to outreach directly to families. We make multiple phone calls and we use it as a touch point opportunity just to find out how they're doing and provide education on case management services, because we haven't heard from everybody, throughout the year, or perhaps they weren't aware in some way. So every year we reach out directly and contact all of our families to see how they're doing and what services we can provide for them. And then under the whole child model approach, the families do contact one entity, which is us as the care plan, and it allows us to provide the opportunity for them to explain their needs once to a single point of contact. And that does allow for a greater continuity of care as the nurse case manager works with the family to create individualized care plans with goals and timelines that are appropriate for that member. So they may call with one issue, and that might be the most urgent issue, but that doesn't mean that we can't listen to their other needs and then create a timeline that works for them and remain in contact with them during that time. I did put our 1-800 number up here because that is the main phone number for our whole entire care coordination team. There are multiple people that answer that phone call every single minute of every single day. Well, I'm going to say Monday through Friday from 8 to 5. And all that the families have to do is either ask for their case manager by name or extension. And if they happen to forget both, they can ask that person who answered the phone, who is part of the care coordination team, who they last spoke to or who their point of contact is, and the person who answers the line will be able to connect them directly to them. We do work as a team in the care coordination department. So it's actually really helpful when it comes to urgent matters that require timely and accurate communication. Definitely, if at all possible, the primary point of contact will take lead on the urgent request. But if for some reason that point of contact is out of the office or unavailable, we have many experienced nurse case managers who can just step right in and assist when services are needed during the same day or within a short turnaround period. For less urgent matters, and it's not the ideal way to contact, but we do also have a member portal that communication can be shared and information can be viewed for all of our members. But I would highlight that that is absolutely only for non-urgent requests. Next slide, please. So I know that both Emily and Lori had already mentioned some of the services that they have received for their kiddos. So this is, a small but not comprehensive list of the services that our case managers can support families with under the whole child model of care. Next slide. So in regards to monitoring and reporting, there's a lot of different avenues where we receive and also share our CCS enrollment. This process is pretty well built into our partnership organization due to our historical experience with the whole child model process. As always, the source of truth for the reports they come from the counties through CMS Net. This is our regular monitoring through the annual medical review and the CMS 22 reports that the counties provide us monthly to identify not only ongoing members, but also to identify newly enrolled members that have had a new CCS diagnosis in the last 30 days. And these are the most accurate reports, and we review them monthly. Additionally, we have a reporting process through our utility management department. When they are reviewing treatment authorization requests for members that are under 21 years of age with potential CCS, and then potential CCS diagnosis conditions are flagged. When we see that flag, if they also are not already previously identified as a CCS member, we will send a notice to the providers as well as the county offices. So just to let them know that we've identified a member who has a condition that can be classified as a CCS diagnosis, and for the providers to start the referral process for that member so that they can receive the appropriate medical services. And then similarly, the department here at Partnership also does a concurrent review for NICU and high-risk infants so that we can capture those members into our services early after they are born and identified. Let's see here. We have some other safety nets for monitoring CCS enrollment. And one of those is the 834 file, and that flags newly eligible CCS members. This is ultimately a second catchment, as we rarely identify members through this way who haven't already been identified through our normal channels, but it's nice to have a backup to our backup. Because again, I hear that one of the concerns is that we are not identifying members early enough, or that there's been a decrease in CCS diagnosis that's being captured. So we use this as a backup also. And then we also receive reporting data directly from the state, which is something called it's through the Microsoft Business Intelligence, but it's a product for reporting reporting on data specifically in the whole child model section. So we have multiple different ways of which we are able to identify our CCS members. And then, of course, the open communication that we have with every county. So if there are any members found that way, we are able to start working with them. And then in regards to the special care centers, we reach out often and help coordinate visits when possible or address any other needs. In some cases, right, the families just aren't interested in regular case management. And so if that's the case, then we get the special care visit records by either reaching out or by pulling claims data through our claims department. Okay, next slide, please. So in regards to, one of the topics that we were kind of set to talk about here today was the Family Advisory Committee. So the Family Advisory Committee, as most of you know, includes any parents, caregivers, foster parents, community groups, or consumer advocates. And we host a quarterly meeting where families are just engaged and have a network system. We are able to choose guest speakers and work on agenda items together. But we have multiple recruitment methods to engage families in this advisory committee. And these approaches will most definitely be shared with our 10 counties in the upcoming year. We have family advisory information about, and also the quarterly meeting dates can be found on our webpage, which I can share with you in the chat, perhaps whenever I'm done speaking, but I will do that.
Great. And Nicole, sorry to interrupt. Can you wrap it up? Sorry, I know I asked you a lot of complicated questions, but we're going to need to move to the Kaiser folks. Sorry.
I will wrap it up, Lori. Thank you. Well, let's see here. So we meet quarterly with our families in the FAC. We also have a team that works directly with the FAC members within our care coordination team. They're actively engaged. We make phone calls to them regularly. We ask them for agenda items. The other point to the FAC is that we closely monitor recruitment and we report ongoing efforts monthly about our progress to DHCS. Yeah, I think that's it. I can pass it over to Jerry and Gina with Kaiser.
Thank you so much, Nicole. Lots of great information there. And we'll try and follow up on some of that in the Q&A or beyond. So now, yes, Jerry and Gina, floor is yours.
Yeah, no problem. Hopefully you guys can hear me. And appreciate the opportunity to collaborate and kind of tell our story. So I'm Jerry Chang. I'm actually a physician here in Southern California. I think the most impactful way to kind of describe what our approach is and how we can support families is really to kind of speak from the elements that are most relevant. So, as I practice in our HEMONC Specialty Care Center in Southern California, I can tell you that in Kaiser Permanente, we're very unique in the sense that we have the privilege of being both a health plan as well as purveyor of health. And so with that integration, every day we have aspects of our organization that I fully acknowledge can feel very large, impersonal, and daunting at times. But I can tell you that within our ecosystems, both in the North and South, we are made up of thousands and thousands of very compassionate and motivated pediatricians and pediatric specialists. And so I think it's important to understand that there's complexity that we have in our space, and then there's a very well hardwired framework within which we know that we need to partner with outside entities to provision care that is appropriate and evidence-based. But insofar as this conversation in the next few minutes, I'll be certainly providing aspects in the lens from the medical groups and the physicians and the providers that partner with our health plan colleagues to provision and meet the needs and the expectations of the whole child model. So let's start with perhaps the first item, which is the primary point of contact for all children. And I'll welcome Gina here to chime in her role as well. And I can certainly add to that. Gina, do you want to talk about how we satisfy and how we meet just communication?
Absolutely. Can you hear me okay?
Sound great.
Okay,
Yes.
great. Lori, I think our session was supposed to end at 1:05. Can I clarify that?
You can keep going.
Okay.
We'll close it. We'll move to questions at no later than 1:15.
Okay, great. Thank you. So I'm working from the hospital today, so I'm hoping that we don't get interrupted by overhead, but please excuse me for that. As Dr. Chang mentioned, we are pretty integrated and we do work closely together, but in order to ensure that every member who is CCS is connected with a healthcare coordinator, we have done so, and we have systems in place that will assign automatically based on location. And then we have the ability to reassign members if one of our pediatric healthcare coordinators leaves. And so it's done a little bit differently in the South than it is in the North, but I can just say that in the South, we have two teams, one team that really reviews census to look at utilization and to identify and refer on a daily basis. And in the North, we have the same team that are the care coordinators who are also linked to the patients doing the care coordination, who are also then reviewing the census. So although I will say in both places, there is one assigned a healthcare coordinator, and in the North, we have a team assigned. So we have social workers, two social workers on the team that are really secondary case managers. So the nurse case manager has the opportunity to link the patient to a social worker if needed. And so we have systems in place, like I was mentioning, that helps us manage the patient population. It's linked to our electronic medical record. So there's that. Now, let's see. Do you want to go on, Dr. Chang?
Yeah, let's talk about enrollment. Let's talk about enrollment and monitoring. And I'll make comments that, again, we have the unique privilege of being able to integrate the physicians and the health plan together with a singular focus to be able to track members as they traverse our multiple entries of care. We provide very seamless and convenient care because of our strong footprint in the Southern California and Northern California communities. So we want care to be convenient and easy to access. We do, for a fact, and I've been a participant in these conversations with the counties, talking about, making sure we have the proper data reporting structures that are integrated now. I heard mention of the 834 file. We also use that as a potential source of truth, but we also use multiple sources of truth when it comes to adjudicate membership. And I know that, we do heavily rely upon, thanks, Allison, we do heavily rely upon the partnership with the counties to be able to make sure that no member is left behind. But I'll let you, Gina, kind of expand upon enrollment, monitoring, and reporting.
Yeah, sure. Thank you. So we do have databases in both North and South that help us look at the utilization in the hospital and the clinic space. We have nurses that review every single day what visits happened the day before. And that helps us monitor. Now, as far as case management, we actually have a monitoring system built into Epic, our EMR, which helps us look at utilization, and it brings down when a patient was seen in the clinic space or in the hospital, so we can outreach them if necessary. So that helps us monitor. Also, we're really connected with the special care center. So when a child is enrolled in a special care center or seeing a physician such as yourself, Dr. Chang, at Kaiser Permanente, we have the ability from our database to actually pull quarterly reports and share them with the case manager who's in the clinic and make sure that those patients have been seen, or that they have the same patients on their list that we're aware of. And then, as I mentioned, our healthcare care coordinators are linked to patients. And if they are open to active case management or high risk, or there is a care plan, we would be reaching out with them on a monthly basis. Otherwise, we watch the census, we watch when patients are being needed and when patients are being seen, and we're always in contact with the case manager in the clinic space. So that's how we monitor both. I would say our databases allow us to monitor, as well as our Epic system that's been built. We also have a new system that we're currently building on monitoring compliance with the requirements of connecting with members within a certain amount of days when we have new whole child model members, or of course, working through all of our members that are new to us through January 1, when we started managing whole child model members.
Gina, can I just ask a quick clarifying question?
Sure.
Gina, when you refer to you're connected with the special care centers and you have the
Yeah.
ability to pull the data, are these Kaiser special care centers, or do you have that ability with external ones?
No, so yes and no. So here's
favorite
the thing.
answer. Yes.
Yeah, I know. Our reports, so I specifically said if they are enrolled in our Kaiser special care centers, we have a database that allows us to do that. We haven't always put in into our database when a member is linked to an external special care center. So the nurse case manager who is responsible for care coordinating that patient would identify that in the assessment, of course, and care plan. So the full list that we're able to pull isn't 100% as accurate, and we don't have the same kind of relationship, obviously, with the nurse case managers and an external special care center. So we wouldn't do the same due diligence in that way. But that doesn't mean that we cannot ensure that those members are not seeing on an annual basis, because we can see that in Epic through Care Everywhere.
Yeah,
Does that answer your
exactly.
question, Lori?
Yes, thank you.
Yeah, there's multiple ways to get there, Lori, as you know, as Gina mentioned, through sharing of integrated medical records, as well as our county relationships. And I'll just close out our session by addressing the last two components. So SCC access. As Gina mentioned, we have a diversity of internal SCCs, but we also know what our gaps are in terms of other SCCs we don't have and probably will never build. So insofar as that, we do recognize when we need to develop strategic partnerships with local SCCs at other children's hospitals. And we put in that work to connect the teams and seamlessly transition patients accordingly when they're homed at outside SCCs. And then lastly, we've initiated both the family advisory and clinical advisory committees this year. Appreciate Ms. Sato, who spoke earlier, and her engagement in that space as well. So, I think we look forward to hearing your questions. And I can assure you that here at Kaiser Permanente, we will continue to work diligently to meet the needs of our whole child model families.
Thank you, Jerry. Thank you, Gina. Thank you, Nicole. So just to kick things off, and I know I've given this question to all the speakers, so they're aware of it. But we thought, since the goal is how we can all partner as we move forward with Kaiser, creating more whole child model programs in different counties, and of course, partnership expanding with 10 new counties. So this is a great opportunity for us to talk about how we can partner so that we do see a stronger whole child model program that I think addresses the concerns that were identified in the evaluation and concerns that have been raised along the way by families and providers, counties, and others. So let me just start with the plans and then open it up to those speakers. And can all our speakers turn their cameras on so we can see you? And so let's start with the plans. How do you think we can all work together as these new changes are being implemented to assure that we do get a stronger, better, more family-centered, more effective whole child model? So Nicole, you want to start that one off?
Sure, I'd be happy to. Well, I think that we can continue doing similar things to what we're doing, which is frequent meetings where in communication with most counties, almost every month, I have leaders, here in care coordination that have direct contacts with most of the public health agencies. So I think just carrying this conversation on and being able to create an open space for us all to kind of share our experiences and learn how to meet the needs.
I love that answer. I completely agree with you. Meeting with the counties on a regular basis has been really enriching and helpful. Also, I guess what I would request is we would love to have more participation in our family advisory committees. So any referrals that the community has for us that we can add to our family advisory committees, that would be fantastic. But I do love the idea of continuing to connect with our counties. And of course, all of the new counties moving forward, we're already meeting with them.
Okay, well, I'm taking notes and I'm going to be happy to transmit a comment like that to Family Voices. So I think that's a great suggestion of more participation in the FACs. Gina, just a quick clarifying question. Do you have one north and one south, or how are you handling the FAC?
That's correct. That's right. And it's virtual. So it's really easy. And we would definitely be open to ideas for promotion. We continue to promote within and externally, but we're working on it and we're just building. And I would love to get more feedback from our families.
Okay, well, I will be happy to transmit that. And it is great too that you mentioned that, Laurie. Laurie Sato, do you still sit on 2 family advisory committees? Right?
Yeah.
Is that
Well,
right? So
I have been with CalOptima's last year going into this year. And then as Kaiser has started, I'm with them currently as well. So I'm sitting on both.
okay. So there you've got your in-house expert, right? Great.
Thank you.
Other speakers, suggestions that you have for how we can partner so that I think really part of the idea here is we want to try and catch any problems as they arise in real time and figure out ways to solve them. You know, before they get more severe or they get kind of baked in to the process in a way that is not that effective. So, you know, I'm just going to put everybody on the spot because I like doing that. So county representatives, what suggestions would you make based on your experience as whole child model counties?
Go ahead, Meredith, and then I'll jump in.
Perfect. Okay. Yeah, I think, you know, like Nicole said, I agree that building on the work that we've been doing over these past 5 to 6 years, you know, making sure that we are continuing to meet and I think also making sure that as we are looking at some of the, you know, the changes like in AB 118, that we are looking at them in the same way and interpreting them consistently. And even, you know, if needed, getting clarification from DHCS in situations where we're not interpreting those things in the same way. Lael, did you want to add?
I have 2 things to add, and I appreciate you saying that, Meredith, because I think that's really important. I also think as we move forward with both our expansion counties and with Kaiser, that we should be meeting with the current counties and the expansion counties together. For example, I think partnership, we should have the JOC meeting with all the counties so that we're being able to talk about the same things, use the same foundations and building off what we've already done. And the same thing with Kaiser. You know, I think that Christine has sent out an email saying that we'll meet as administrators and MTU together. And I think that's really important as we look at, especially as we've heard here today, that there's issues with DME. Kaiser's a new program, a new plan coming on, and we have a chance to be able to really support the enhancement of how it can move forward in a positive way and build on what we've learned. So I think as we look at both CenCal, Alliance, Kaiser, and partnership expanding, that we look at how we can bring both the expansion and the current counties together.
Yeah, and we did hear Laurie mentioned earlier that there might be the reason it's great to bring the MTP folks in at the same time, because there may be some confusion about how much control does the MTP have over equipment. So that would be another vehicle for helping to sort that through. Francesca, anything you'd add to it?
I think there's been some really great discussions here today, and I know the plans are working really, really hard to make everything successful for their clients and members. I think I would just tone back to the importance of a dedicated case manager and looking at making case management more proactive rather than reactive for these families, because the families need help navigating all of the complexities that they have. They don't have just one specialist, as you heard earlier today. They have 20 specialists, and it's exhaustive for them to try and coordinate all of that care. And I think the need for, very individualized and persistent and ongoing handholding and case management is crucial for these families and for the care of these children.
Yeah, which I think may come back to a discussion after this about who gets access to complex care management, because it seems like that's more focused attention for these kids, and we certainly heard Laurie talk about that. That made a big difference. So Laurie and Emily, any ideas you have for how we can partner to identify and mitigate problems before they get out of hand, or identify things that are working great and promote them?
Something that I think has been really beneficial for us as a family has been to offer telehealth options for families to join. We oftentimes have restrictions. So maybe our nurse called out, or, we're juggling 50 other appointments, and I think that the more flexibility you can offer parents, the more they can participate. I think that also kind of understanding different venues from which you can recruit these families. I think that for my daughter personally, I know that she and a lot of her friends, we see each other often in certain offices. So maybe at the MTU, or maybe we're in the neurology office, or we're in the genetic counseling office, or, a lot of times we see each other in kind of these shared spaces. So kind of thinking how you can maybe communicate with families that are in these spaces as they're running from appointment to appointment. Obviously there's good times to catch people and bad times, but I think that wherever you can, I think just kind of getting that communication out there, and so that they can see, okay, well, what is the involvement? Okay, 1 hour every 3 months, I can do that. I think that that would be really beneficial to help them understand, and also help them understand how it would benefit them. We've gotten a lot of useful information for our own family by participating in the FACs, just kind of having the various speakers and kind of having people have topics that are applicable to us. Has been truly beneficial. So I think that once families know kind of what that would mean for them, I think would be helpful, because we're so committed to so many different things. And so helping us bite off what we can chew is really beneficial.
Great. Emily.
Thanks. I was just going to support the need for a good case manager and the proactivity to, just let us families know what is available. There's been many times when I go and ask a doctor for something and they say, I don't know. And and later I would find out that it was something that CCS could help us with. And it would be great to be able to get that rolling faster so that we're not waiting for months and months for something that we need. So, but thank you.
Great. Thank you,
That's
Emily.
That's a great point. I'll just say, Emily, because, obviously we've been doing a lot of education around physicians and frontline staff about the programs. And as you mentioned, there's an absolute gap there. So yeah, the more people know on the front lines what's available to families like yourself, the better we'll all be. So thanks for your comments.
Agreed. Mira, anything you want to add to ideas that from the advocate perspective for how we could partner?
I'm one of those people that's kind of like the funnel for all the information that all of you are doing and all the conversations you're having on the ground. But I would always say that Laurie does a great job of getting that information to me. We have a good partnership with Family Voices, but I would just open myself up to anybody who's listening or anybody on this panel. We're always here to kind of help connect people. I'm living in Sacramento and I'm kind of doing the advocacy thing, but to the extent that I can help bring more conversations together and help connect things that you're talking about and trying to figure out how to do it at the state level. I think CCHA can be really helpful there, and just want to put ourselves out there as a resource when you have those types of issues.
Thanks, Mira. So I think we'll close now. I know that the next session is beginning promptly at 1:30. So I want to thank all the speakers today. And, again, we are all here because we care about kids and their families. So I think this is a great opportunity for us to continue the dialogue about how we work together to make the world work better for kids with complex conditions and their families. And I feel like this is a good start. So you will all be hearing more from us as the year unfolds and we approach 2025. Thanks again. And I think everybody's supposed to go back to the lobby. Yes, when the session ends, you'll see I can read chat. You'll see the event lobby page and you click to join for today's closing session. So again, thank you all. Thanks to Family Voices. Thanks again to Allison. Thanks above all to the families for making this possible, and see you at 1:30 in the main session. Bye.
Lori, I'm going to end the session now.
Okay, thank you,
Okay.
Allison.
Thank you. This was wonderful. Have a great day.
You too.
Bye.